And the Netherlands study, the HIPROS trial, treated 3 times a week rather than 5 times a week. Now, they did that for a very good reason. That's why the retrospectoscope is so useful. And it's actually, I think it teaches us something about radiobiology. Now, happily for me, there was a meta-analysis that was published in April this year, which saves a lot of going over the same data again and again. And they looked at the trials, all but one of the smaller trial published this year, separating them into the isodose trials and the dose-escalated trials in the same way. You can see that for efficacy, the hazard ratios were just a little bit in favor of hyperfractionation, but the p-values are non-significant, but no difference between the isodose and the dose-escalated. In terms of side effects, now I'm showing you the patient-reported outcomes here using the EPIC scale. For the isodose trials, green bladder, red for GI, you can see that the hazard ratios are really pretty favorable for hyperfractionation. But for the dose escalation trials, the hazard ratios are over 1, and that's statistically significant for the GI side effects. So dose escalation does produce more side effects. That's not really a very big surprise, actually, because we know that dose escalation using conventional fractionation causes more side effects. So the conclusion from the meta-analysis was that adequate evidence for radiotherapy delivering 60 Gray in 20 fractions over 4 weeks is the standard schedule for all patients with localized prostate cancer. Unequivocal statement, with which I happen to agree. Some quick thoughts on radiobiology. Why did we think the alpha-beta ratio was low? Well, that was because Brenner and Hall, back in 1999, when they compared external beam radiotherapy with iodine-125 seed implantation, so very different treatments, they came out with a calculation that the alpha-beta ratio was 1.5 Gray. I think that's a very clever piece of work that was done. It might be refined. Soren Benson and colleagues and others have suggested there may be a time factor involved, and their best guess was that it was 0.31 Gray per day. Time factors are, I'm not going to discuss this in detail because it's complicated. You can have some coffee with me afterwards if you want. Are very complicated. You don't know when to start the time factor. Is there a kickoff time? Is it a linear relationship? Is it some sort of polynomial relationship? This is a linear relationship going from origin at 0.31 Gray. But when we look at those trials, we find that the PROPHET trial, alpha-beta ratio of 1.3 Gray. CHIP trial, 1.8 Gray is the estimate. Now that's using hormone treatment as well, which could potentially have an impact. The HIPRO trial, much higher, 3.5 Gray. And the RTOG trial in the low-risk patients, right up at 6.9 Gray. If you put Vergilius and Benson's time factor in, though, those alpha-beta ratios cluster at about 4.6 Gray. So the alpha-beta ratio of the time factor may not be as low as we used to think. Now, the other side of the coin is normal tissues. Now, if you've been thinking about the ISO effect on efficacy and side effects, you might have thought, well, why isn't the radiobiology therefore the same for those normal tissues and tumor? Why shouldn't it be the same if actually you're having the same result? But that means that something is being misunderstood, because we've always said that the alpha-beta ratio for late effects was 3 to 5 Gray, and we've always said that prostate cancer was 1.5 Gray, or thereabouts. Douglas Brand, one of our research fellows, did a very sophisticated, detailed analysis of the CHIP trial, and he looked at 6 GI endpoints: bleeding, diarrhea, pain, proctitis, sphincter control, and stricture, and came out with an alpha-beta ratio on average of 2.4 Gray, but varying between 1.6 and 3.1 Gray for various endpoints. And for the genitourinary side effects, 0.6 Gray for hematuria and 2.0 Gray for dysuria, so much lower than has previously been suggested, and actually in the same ballpark as we think of for prostate cancer without a time factor. The analysis that Douglas didn't have a time factor in. Now, it has crossed my mind that it is quite likely that the alpha-beta ratio and time factors for different normal tissue reactions are probably not the same. It has also crossed my mind that it is extraordinarily difficult to get enough data to actually prove what they really are. And what I think is going to be really helpful is to learn from the ultra-hyperfractionation SBRT trials when we're using 6 Gray or more per fraction and much shorter time intervals, what actually happens in those studies. I was specifically asked not to talk about those studies in this presentation, so I've done as much as I'm going to. Now, what about resource savings? You've already heard about this from Corinne, but here's my simple slide. Well, what about patients? Time, traveling, loss of earnings, all sorts of things. Much more convenient. And some calculations on healthcare impacts. UK, 28 million per year, going from conventional to modest hyperfractionation. In the USA, $360 million. Globally, in the Lancet Oncology Review, $2.55 billion. And that would actually allow almost 1 million more patients to be treated. So it has a huge impact, practically, as well as being apparently, and I believe it, no disadvantage to patients. I took out my slide on the green effects of hyperfractionation. I'm very pleased that I did, because it's already been dealt with by Corinne. And obviously the same goes for prostate cancer as any other cancer. So my conclusion is the MARCAP Consortium conclusion. There is adequate evidence for radiotherapy delivering 60 Gray in 20 fractions over 4 weeks, and it's really important it is 4 weeks and it's not protracted. Should be the standard schedule for all patients with localized prostate cancer. Thank you very much.
Thank you very much for this talk, and just to remind you that we will have a session about hypofractionation and its consequences on so financial consequences, and also on how to organize our structures and establishments tomorrow. Are there some questions from the floor? Stéphane?
Juste devant Stéphane. En attendant qu'ils prennent la parole, hein. Demain, il y aura la suite un petit peu de l'hypofractionnement avec la session SFRO, SFJRO sur les autres types de cancers. C'est demain à 16h.
Thank you, David, for this very nice presentation. We know that ultra-hypofractionated radiotherapy is another option in low-risk and intermediate-risk prostate cancer. Is there still room for hypofractionated radiotherapy?
I'm sorry, I didn't quite catch the question. Can you put the mic a little bit nearer?
Oh, sorry.
That's better.
SBRT is another option for low and intermediate-risk prostate cancer. Is there still room for hypofractionated, modestly hypofractionated radiotherapy in low and intermediate-risk prostate cancer, in your thought?
So if I've understood the question correctly, is there room for modest hyperfractionation rather than SBRT? Well, I think my answer to that is that I would be very optimistic that ultra-hyperfractionated radiotherapy, whether you want to call it SBRT or not, probably is going to be what is used in 5 years' time as the routine. But if you take the evidence from that, from the trials run by Nick Van Ass and Alison Tree, and of course Anders Widmark, and it's sort of like we were 5 years ago with modest hyperfractionation. So some people and I think possibly very much in the UK, will be saying, give us that 5-year data and we'll tick the box. Other people will say, we need the 10, 15-year data. And it depends how cautious you are. And I mean, quite honestly, I don't know what the results are going to be, but I think I have a strong hunch that it's going to be in favour of ultra hyperfractionation. I'm going to throw you a phrase, and that is that I think that probably the therapeutic ratio is agnostic to fractionation schedule. That may not apply once you get much under 5 fractions. I don't know whether you can go down. I think we know we can't go to 1 fraction, but 2 or 3 fractions may be possible. We don't know that. It's being tested. But I think that is the direction of travel. And it may be that there are... I would love to be able to tweak the time factors and the alpha-beta ratios and to really know what those are so that we could answer the questions. But we just need masses more data to do that.
Thank you very much. Is there any other question? Yeah.
Thank you very much, Professor Dernallé, for this wonderful talk. I was thinking about pelvic lymph node irradiation because I hear quite a lot of physicians who don't want to do moderate hypofractionation because in the high risk, they want to irradiate pelvic lymph node. What do you think about this?
Okay, it's a very good question. There is information now coming out on modest hyperfractionation and indeed extreme hyperfractionation for pelvic lymph nodes. The latter from Vidam Murthy's group in India used a modest dose, but toxicity was fine. My own view and biases, having treated with hyperfractionation a number of 100 patients, is that it is fine, provided you don't push the dose up too high. But our group have treated the pelvis up to 60 Gray in a 20 fraction schedule, and that was okay. But you must use IMRT, you must use dose constraints, and you must avoid treating bowel as far as you can. So the technology and the biology of hyperfractionation have gone hand in hand, and I don't think it would be wise to separate them. So high quality radiotherapy, I think it'll be fine.
Thank you very much.
Thank you very much for these answers and for the talk.
Thank you.
C'est maintenant le temps. Thank you very much. Le temps de passer à la remise de médailles. Je vais demander au docteur Jean-Christophe Fèvre de s'approcher, ainsi qu'au docteur Valérie Bernier. Donc, cette médaille de la SFRO, elle est remise à des oncologues radiothérapeutes qui sont partis en retraite et qui ont apporté au cours de leur carrière des travaux et un investissement auprès de notre spécialité qui est reconnue et dont on veut les remercier.